Welcome to the DeSera Clinical Education, formerly CCO, Infectious Disease Podcast. I'm your host, Dr. Karen Straube-West. In today's episode, we'll explore the advantages and potential pitfalls of different HIV testing algorithms with two experts in the field to find out which one is best suited for your practice. To listen to other podcasts in this series, please visit the show notes. Now let's get started.
Welcome, everyone. My name is Hazra at the University of Chicago, and I'm joined here by...
I'm Nancy Miller, the Medical Director for Clinical Microbiology at Boston Medical Center in Boston, Massachusetts, and Boston University School of Medicine.
We must often remind our colleagues that the cornerstone of HIV care prevention is quite simple. It really begins with a test. You cannot treat what you cannot diagnose, and in 2025, that truth is more urgent than ever. Despite advancements in prevention and treatment, we continue to see delays in HIV diagnosis across the country. Nearly 1 in 8 people living with HIV remain unaware of their status, and 1 in 5 people with HIV present with advanced disease at the time of their diagnosis. These numbers aren't just statistics, rather they represent missed opportunities along the HIV care cascade. Late diagnoses cost lives, increase downstream transmission, and undermine our collective efforts to end the HIV epidemic. The case for routine, universal HIV screening is our most powerful tool to bridge this gap. The United States Center for Disease Control and Prevention has long recommended opt-out HIV screening for all individuals 13 to 64 in settings where the prevalence of undiagnosed HIV is at least 0.1%. However, in practice, implementation remains uneven and is often confined to so-called quote-unquote high-risk clinics or populations. My own institutional experience with electronic medical record-driven opt-out HIV screening in both adult and pediatric emergency departments highlight the transformative potential of routine testing. It helps identify acute infections, reconnect people who have fallen out of care, and dismantle stigma surrounding HIV screening in real time. HIV does not discriminate, but all too often our health systems do. Universal testing is a step towards equity, dignity, and overall better health outcomes. Advantages and pitfalls of HIV diagnostics algorithms. In 2018, the CDC published a 3-step HIV diagnostic algorithm, starting with the 4th-generation HIV antigen antibody test, followed by an HIV 1-2 antibody differentiation immunoassay, and, if needed, a nucleic acid amplification test to resolve any discordant results. This approach improves the detection of acute HIV infection, but involves longer turnaround times that can often delay diagnosis and linkage to care, especially in resource-limited settings. In 2023, the CDC provided a technical update acknowledging, but not fully endorsing, a 2-step model. Antigen antibody testing followed directly by nucleic acid amplification testing, which could, in the future, accelerate diagnosis in high-incidence settings like emergency departments and STI clinics. Still, NAT testing has its own limitations. Sensitivity varies across platforms. Some detect total nucleic acid, others only viral RNA. An additional limitation includes availability issues for lesser resource labs for the 2nd-step NAT. Despite new HIV RNA-based assays, FDA cleared a 2nd step in HIV screening algorithm. As testing strategies evolve, alignment across clinicians, laboratorians, and public health partners is essential to ensure that the right assays are matched to the right populations, balancing sensitivity, turnaround time, and cost. The need for accurate, timely HIV screening is even greater as more people use oral and long-acting pre-existing prophylaxis or PrEP. These agents, while transformative for HIV prevention, bring unique diagnostic challenges. Breakthrough infections are rare on PrEP, but when they do happen, particularly with long-acting agents, they may involve low-level viremia or delayed seroconversion where our standard antigen antibody tests may miss early infections. NAT testing offers the potential to detect these early infections, but its role in primary screening remains highly contested. The current CDC PrEP guidelines recommend combining HIV antigen antibody testing with NAT for all individuals on PrEP to ensure accurate screening. However, integrating NAT into routine PrEP monitoring presents real-world challenges. NATs are more expensive, may not be covered by insurance, and often require centralized lab processing. Additionally, data from the HP1083 open-label extension shows that HIV RNA screening has limited accuracy in people using long-acting cabotegravir or LA-CAB for PrEP. with most isolated RNA positive results determined to be false positives. To this end, the International AIDS Society, or IAS, no longer recommends routine HIV RNA testing for people using LA-CAP for PrEP, although the CDC has yet to follow suit. Instead, IAS guidelines suggest a point-of-care rapid HIV antibody test and a laboratory-based antigen antibody test as part of routine monitoring for people taking LA-CAP for PrEP. For people using lenacapavir as PrEP, IAS recommends HIV testing with laboratory-based antigen antibody assay at initiation, and HIV RNA testing is recommended at initiation for individuals with high likelihood of HIV exposure in the past 21 days, and at each injection visit, that is, every 6 months. For individuals with frequent exposure to HIV, HIV testing is also recommended with interval STI testing every 3 months. A rapid point-of-care test may be used during this interval testing if a laboratory-based antigen antibody testing is unavailable.
Thank you, Dr. Hazra. We'll now move ahead and talk about the road ahead, testing as prevention and testing as care. As we move closer to the goal of ending the HIV epidemic, our strategies for testing must evolve alongside our tools for prevention. Universal routine HIV screening remains a cornerstone of HIV care and prevention, but we must also ensure that our diagnostic algorithms are responsive to the nuances introduced by long-acting PrEP and other emerging biomedical interventions, as Dr. Hazra just pointed out. So I'll now proceed to outline briefly what we call a tale of 3 HIV algorithms. With how common missed or delayed HIV diagnosis can be, it is difficult to know whether we are doing HIV testing so-called right. Each HIV testing algorithm has its advantages and disadvantages, to be sure. The key is determining which to use in each patient scenario. First, two-step serology. The CDC preferred algorithm currently consists of a two-step conditional reflex serology with resolution of discordant results via nucleic acid amplification testing, abbreviated as NAT. Step 1 of the two-step serology is a laboratory-based antigen antibody assay, either 4th or 5th generation HIV serology that detects both HIV-1 and HIV-2 antibodies and also HIV-1 P24 antigen, which is a marker for acute infection prior to seroconversion. If step 1 of this algorithm is reactive, step 2 is an HIV antibody discrimination assay for specific determination of HIV-1 and or HIV-2 antibody. Notably, antibody discrimination assay does not detect the P24 antigen. So finally, if there's a discrepancy between steps 1 and 2, between the initial screen and the follow-up antibody discrimination assay, step 3 is a NAT test to rule out acute HIV infection. NAT options include diagnostic assay detection of HIV-1 RNA or proviral DNA. Of note, 4th generation serology does not differentiate between detection of antibody or antigen, while 5th generation serology does. Certain 5th generation assays are also designed to distinguish between HIV-1 and HIV-2 antibodies. However, on-label use of 5th generation assays may still require a confirmatory follow-up test if initial screening is reactive. Notably, the CDC preferred algorithm has not yet been updated to utilize 5th generation assays as a one-and-done test. Advantage of this two-step algorithm method includes detection of HIV-2 antibodies after the initial immunoassay. This aids monitoring and therapy for HIV-2, which differs from that for HIV-1. This method also provides public health departments with data to track possible acute cases by virtue of the P24 antigen that's included in the 4th and 5th generation tests, and by the discrepancies that can arise between the initial screening and a follow-up test with antibody discrimination in cases of acute infection. However, there are disadvantages to the number of steps potentially involved in this algorithm in terms of the test burden for laboratories. Furthermore, laboratories without resources to perform all these steps in-house incur increased operational costs for outsourcing tests and may experience delays in turnaround time for results. Now I'll turn to serology with NAT, an alternative algorithm. This has been acknowledged by the CDC, but is not yet preferred. It involves fourth or fifth generation serology testing with a conditional reflex instead to NAT discrimination testing, with resolution of discrepant results via a third-step antibody discrimination assay. Here, examples of discrepancies include false positive results from the initial screen, undetectable viremia in a seroconverted patient taking PrEP, an elite controller with HIV RNA below assay level of detection, or potentially virus unable to be amplified and detected due to nucleic acid sequence mismatch. This testing algorithm, starting with serology and using a NAT as the second step for discrimination testing, facilitates HIV screening as it may be implemented as part of a serum-to-serum reflex conditional reflex testing and/or as a serum-to-plasma conditional reflex protocol in a laboratory. Performing testing this way may also reduce the rate of discrepant results compared to the two-step conditional reflex serology algorithm. However, pitfalls of the algorithm that includes a second step using NAT instead of antibody discrimination are several, including insufficient serum quantities to complete the algorithm, necessitating a second serum sample or a plasma sample for follow-up HIV RNA testing, with or without subsequent viral load testing. Also, if a batched workflow for the second step NAT is used in a laboratory, adequate turnaround time for result disposition may be a challenge. Another potential pitfall is that this algorithm may produce false negative results in people with a history of PrEP, individuals who are elite suppressors, or people with genetic escape variants. So reliance on a NAT for second step discrimination testing has both its advantages and disadvantages compared to the two-step serology test using NAT as a third step only. Now, what about one-step NAT? One may wonder, why not just skip the serology tests entirely? There happens to be an alternative one-step diagnostic option using a NAT test. Primary diagnosis of HIV infection by NAT, serum or plasma, with or without follow-up serology to document seroconversion is now available. This is a strategy best used for suspected acute HIV infection prior to seroconversion in a treatment-naive person. If positive, a follow-up HIV quantitative RNA test for baseline viral load can help affirm that the diagnostic qualitative RNA PCR result is a true positive, in which case one would expect an acute infection to have a fairly high viral load. And this would be in the absence of antibody seroconversion data. If clinical suspicion warrants, additional testing for HIV-2 may be required if an HIV-1 assay yields a negative result. There are currently 3 HIV NAT assays FDA approved for a diagnostic indication such as this. The primary advantage of this algorithm is that it enables a one-and-done diagnostic for suspected seronegative infection. An RNA-based diagnostic option can mitigate misuse of the HIV viral load as a diagnostic in settings where the viral load has not been verified for use as a diagnostic. In other words, has not been allowed to be used by current regulatory parameters as a one-and-done diagnostic. Having an in-house option of HIV RNA testing, in addition to serology, also provides the ability to implement recommended test algorithms for patients on PrEP when both methods are needed. However, this one-and-done RNA method does not provide serology profile at baseline if documentation of serostatus is indeed desired, and it may also result in false negative results for people with a history of PrEP use, people who are elite suppressors, or those who have genetic escape variants. This one-and-done PCR method is also most efficiently performed with a batched workflow, which could present challenges to adequate turnaround time.
Thank you so much, Dr. Miller, for those incredible insights. And lastly, I think we would like to just think about overall considerations and challenges for implementation of HIV testing. Regardless of algorithm workflows, we find that robust test utilization tools are recommended to ensure proper test orders, proper use of one-step RNA testing, and to ensure proper follow-up testing is warranted. Another important consideration is planning for optimal specimen volumes and serum plasma options to allow for both diagnostic testing and follow-up viral load after a reactive result. For example, creating a separate HIV order set selection panel in the EHR system facilitates compliance with proper test utilization for diagnostic versus therapeutic monitoring. A separate HIV order also is helpful for cost control and ensuring correct tubes are drawn for plasma, serum, or whole blood. Utilizing dedicated test orders, batteries, and packages as warranted for HIV tests also enables algorithmic results to display as dependent components of a conditional multi-step process and minimizes the risk of misinterpreting or missing one of the several dependent test results. Finally, healthcare providers must be mindful of local laws governing HIV testing and consent for minors, and ensuring adequate data stream to public health departments as required. Ultimately, the path forward requires clinical vigilance, laboratory innovation, and system-wide commitment to meeting patients where they're at with the right test at the right time. Thank you so much for joining us. Again, this is Aniruddha Hazra from the University of Chicago, joined by my colleague, Dr. Nancy Miller at Boston Medical Center and Boston University School of Medicine. We appreciate your time.
Thank you, Dr. Hazra and Dr. Miller, and many thanks to you, our listeners, for joining us. To listen to other podcasts in this series, please click the link in the show notes. To get access to all of our new podcasts, subscribe to DeSera Clinical Education, formerly CCO, Infectious Disease Podcast on your favorite player. Thank you, and have a great day.